Good morning. I welcome everybody from all around the world to this webinar on abnormal uterine bleeding in the perimenopause and the postmenopausal woman. And I welcome everybody from around the world. My name is Wendy Wolfman, and I'm a professor in the Department of Obstetrics and Gynecology at the University of Toronto. And it's a beautiful early fall day here. And I hope the weather is good in this hopefully post-COVID era. And today we have two illustrious speakers. The plan is to present each speaker right before their talks. And you can keep your questions to the end, and we will answer your questions and have a lively discussion. This webinar was supported by an unrestricted educational grant from Bessan Healthcare. Bessan Healthcare had no role in the selection of topics, selection of speakers, and have not vetted or reviewed the content of the speakers' presentations. So we'll move on now to our first speaker. Our first speaker is Dr. Stephen Goldstein. He's a professor of obstetrics and gynecology and director of gynecologic ultrasound at New York University School of Medicine. He is currently president of the International Menopause Society, and he is past president and fellow of the American Institute of Ultrasound and Medicine, as well as being the past president of the North American Menopause Society. He really has a long and illustrious CV. I won't go through every detail, but in 2016, he received the Clarkson Award from NAMS for Lifetime Achievement in Menopause Research, and in 2019, the Joseph Holmes Clinical Pioneer Award from the American Institute of Ultrasound and Medicine. He's published 7 books on women's health topics, and he's authored more than 60 chapters in textbooks, as well as 80 original research articles. He is really one of the most highly recognized and regarded individuals in the field of the vaginal probe ultrasound worldwide. And he's been a guest faculty member, invited speaker, visiting professor, or course director over 400 times. This makes 401 throughout the United States and the world. And we're so delighted to have Steve here to impart his clinical knowledge and experience. And I also want to invite everybody to the International Menopause Society meeting between October 25th to 29th, where Steve is still the president. So thank you very much. Go ahead, Steve.
Thank you very much. So as we mentioned, the topic is evaluation of peri and postmenopausal bleeding. And the question I would ask is, who are you? It may seem funny. If you're a gynecologist, you will likely be responsible for performing many of the evaluations that I'm going to describe. And if you're not a gynecologist performing them, then you should at least have an expectation of what the healthcare provider that you refer to can and should be doing. So many of you by now have heard the FIGO nomenclature of POM coin for abnormal uterine bleeding. The POM stands for structural abnormalities: polyp, adenomyosis, leiomyoma, malignancy, and hyperplasia. The coincide: coagulopathy, ovulatory dysfunction, endometrial sources, iatrogenic and not otherwise specified. But really, to simplify this for you, it really is structural versus non-structural. And as a clinician, this means to me, if it's structural, I'm going to be doing operative hysteroscopy, versus hormonal or expectant management if it's non-structural, which is really the next speaker's topic. So realize, to our patients, all the blood that comes out of their vagina is their period. But to me, a menses is a bleed that's preceded 2 weeks before by ovulation, or if they're menopausal on non-sequential hormone therapy, then it would be a progesterone-induced bleed. Furthermore, Postmenopausal bleeding is really not so easily defined. We know that menopause is the final menstrual period, but this is a retrospective diagnosis. Somebody who has just bled doesn't ever realize that that's the last bleed they're ever going to get. So we also use a classic definition of no bleeding for 12 months due to a depletion of ovarian follicles. And so I hope you realize that if you measure follicle stimulating hormone and estradiol, that's a snapshot of ovarian function at that time, is not necessarily a reliable indicator that there will never be any more erratic ovarian function. In fact, it's this erratic ovarian function in late perimenopause that often makes it very difficult to label someone's bleeding as being definitively postmenopausal, but it may not really matter, because we even teach our medical students that any postmenopausal bleeding is endometrial cancer until proven otherwise. And this mandates an evaluation. And at least here in the States, the American College of OBGYN Practice Bulletin from 2012, reaffirmed several times since, mandates that endometrial assessment to exclude cancer is indicated in any woman older than 40 years of age who's suspected of having abnormal uterine bleeding. So anything like in this framework needs to be evaluated. I say here that you can use transvaginal ultrasound as the first step in the evaluation of abnormal bleeding in all cases, as long as you understand the difference between patients who cycle versus those who do not. In non-cycling patients, every day is the same, so the timing of when you do your ultrasound is not important. But in patients who cycle, timing is crucial. Ultrasound evaluation should be performed at a time when the endometrium will be as thin as it will be all month long, just as the bleeding ends. And this will prevent misinterpretation of some heterogeneously thickened endometrium later in the cycle as being pathologic, something we've referred to as endometrial moguls for those of you who ski. Well, what about bleeding on hormone therapy? When does that need to be evaluated? If patients are on sequential hormone therapy, as I've already mentioned, you'd like to evaluate them as soon as possible after that withdrawal bleed. Otherwise, you will get many, many false positives, because if you're giving them estrogen, you thicken their endometrium clearly. But if you then withdraw them with sequential progestogen, that should be when the endometrium will be as thin as it's going to be. In patients who are on continuous combined hormone therapy, you expect a fairly thin endometrial echo, although normative data hasn't really been established. But I show you this slide, which I think is very important. And this is actually from the SMART trial with bazodoxifene, combination with conjugated estrogen, known in parts of the world as Duaviv. In the States, it was Duaviv. But the reason I'm showing you this, because this is the Duaviv and the placebo line, this was now Prempro. Okay, this was Prempro 0.45 with medroxyprogesterone acetate. And I show you this because in the first four-week cycles, the incidence of any bleeding or spotting ranged from 21 to 26%. And at 1 year, it was still close to 9%. So when I put a patient on continuous combined hormone therapy, I often say to her, if you have any bleeding or spotting in the first 4 months, don't call me, because this is almost to be expected. But after that, I will evaluate their endometrium, although keeping in mind that as many as close to 9% of these patients may bleed. So I ask here, what's the proper use of transvaginal ultrasound in the clinical evaluation of patients, assuming you've performed it at the proper time, the way we just spoke about? And the answer is the high negative predictive value of a thin, distinct echo on transvaginal ultrasound in patients with bleeding. Non-bleeding patients are an entirely different story that we're not dealing with today. In my first book, I coined a phrase, sonomicroscopy, because I put forth to you that the vaginal probe gives you a degree of image magnification that's as if we're doing our ultrasound through a low power microscope. We are seeing things with the vaginal probe that you could not see with your naked eye if you could hold it at arm's length in your hand and squint at it. So for instance, here now is an embryo of 3 millimeters at 45 days from the last menstrual period. Cardiac pulsations are clearly visible in this 3 millimeter embryo. You couldn't see this with your naked eye, But with a vaginal probe, we can. We're looking through a low power microscope. This is some of the beauty of the vaginal probe, also some of the potential pitfalls. Hormonal status obviously affects endometrial thickness. The endometrium consists of a basalis and a functionalis. Estrogen causes the functionalis to proliferate. So here now on day 8 of a new cycle, you see this trilaminar appearance of the endometrium in the proliferative phase prior to ovulation. Progesterone, or in sequential hormone therapy, the use of a progestogen, will convert an estrogen-primed endometrial functionalis to a secretory phase. Secretory endometrium will appear thick and echogenic on transvaginal ultrasound, and so you have this thick, echogenic, homogeneous endometrium in the secretory phase. After shedding of the functionalis, the basal endometrium that remains is initially quite thin and has what I call a pencil line appearance on transvaginal ultrasound. So the day after a menses, this white line, and please don't call it a stripe, this represents the interface between two sides of inactive basalis endometrium. In menopause, there's no estrogenic stimulation of the functionalis, and the endometrium is atrophic. And here's a hysterectomy specimen taken on a menopausal patient. The surface epithelium is a single layer of low cuboidal epithelium. And if you look at the glands here, there are virtually no mitotic figures because it's not proliferating. And if we look at a postmenopausal patient, this thin white line once again represents the interface between two sides of inactive atrophic endometrium. Well, I talk about historical perspective. Consistently in the early 90s, the finding of a thin, distinct endometrial echo, and whether you used 4 or 5 millimeters as a magic number, was effectively shown to exclude significant tissue in these postmenopausal women who were bleeding. So here's a 64-year-old woman, wakes up with a big spot of blood in her underwear. She comes in, we put the vaginal probe in. She's got this thin, distinct endometrial echo. This excludes the presence of significant tissue. Or here's another example. The cervix is up here. Here's the uterine fundus, a thin, distinct endometrial echo with a nice intact hypoechoic zone surrounding it, reliably predicts the lack of significant tissue. We were the first ones to really publish on this in an observational study of 26 patients. Varner, then a year later, and Granberg, both out of Europe, found similar findings. But these needed to be validated. These were early observational studies, and so some large prospective trials came out of mainly Western Europe. The Nordic trial, 1,168 patients with postmenopausal bleeding for an endometrial thickness less than or equal to 4 millimeters, there were no cancers. Enrico Ferrazzi, a multi-center trial in Italy, 930 patients, less than or equal to 4 millimeters, 2 cancers, less than or equal to 5 millimeters, 4 cancers. Barrett Gull, Elizabeth Epstein, Barrett Gull. And if you combine all of these prospective studies in women with bleeding, for an endometrial echo less than or equal to 4 millimeters, the incidence of malignancy was 1 in 917. Well, the question comes up, should you even still do a biopsy on a patient like this? We said that the false negative rate of a transvaginal ultrasound less than or equal to 4 millimeters is going to be very, very, very low. And it's significantly less than a negative suction piston biopsy, and I'm going to talk about that. In fact, this study showed that if you do a biopsy on a patient with an endometrium less than 5 millimeters, only 82% of the time was it even successfully performed, and of those, only 27% gave enough tissue adequate for a histologic diagnosis. So in 2009, notice this is 19 years after our observational study, the ACOG G1 Practice Committee came out and said, when transvaginal ultrasound is performed for patients with postmenopausal bleeding and an endometrial thickness less than or equal to 4 millimeters is found, endometrial sampling is not required. They have updated this data. They now have added some data out of China from Wang, over 4,300 patients. And they've divided this into, for an endometrial echo less than or equal to 3 millimeters, the chance of cancer 1 in 383, 4 millimeters 1 in 339, 5 millimeters 1 in 239. But the document still says for the average risk woman, the current standard of less than or equal to 4 millimeters as a cutoff, beneath which no further evaluation is necessary, is still acceptable. However, for higher risk women, obese, hypertensive, diabetic, history of polycystic ovarian syndrome, or patients who rebleed, then further evaluation, in spite of an initial thin ultrasound echo, may be warranted. So if we're going to use ultrasound, what else is essential? Well, you want to use the highest frequency transducer that gives you adequate penetration. You want to get multiple images in the long axis plane to the midline and right and left of the midline. And when you measure, you want to measure at the thickest point perpendicular to the echo. So for instance, here is a patient with a thick endometrial echo. This would be the proper way at a right angle to measure this. This would not be the proper way at a skewed angle to measure this. Here's a thin endometrial echo in a patient with bleeding. Notice, interesting, the machine will measure to 1,000th of a centimeter. Talk about significant digits. This is 1.2 millimeters in thickness. But it's important to understand that not all uteri lend themselves to a meaningful ultrasound examination. The axial uterus, marked obesity, coexisting fibroids, adenomyosis, previous surgery. Just because you can wiggle the transducer and produce something that's linear and white and freeze the frame doesn't mean you should. When an endometrial echo is not totally distinct, you must not be afraid to indicate that the endometrial echo is not well visualized. So here's an example where I am confident of my endometrial echo and ruling out significant tissue. And another example, she's 6 years postmenopausal. This is reliable. It measured 1.2 millimeters, another case like that. Here's one where it's reliable, but it's thick. It's measuring 8.1 millimeters. In this woman who's bleeding, this is not acceptable. This doesn't prove inactive atrophic endometrium. Here's a woman with a number of fibroids. You can see the acoustic shadowing that's produced by these myomas. I can't tell you what really endometrial echo is. I can't use my transvaginal ultrasound in a patient like this. Or here's a lady with a submucous myoma. Yeah, you're seeing a little bit of the endometrial echo, but I really don't know what's going on here near the fundus. And so I can't rely on endometrial thickness in a patient like this. This woman's got marked adenomyosis. I can't tell you what her endometrial echo measures. So not all uteri lend themselves to meaningful examination. And here's a woman, this is typical of a C-section. The cervix comes in anteriorly and the fundus takes this 90-degree dive, posteriorly. These abnormalities are not always global. Realize if you produce a still two-dimensional image on transvaginal ultrasound, that's a snapshot. And so for instance, here's a long axis view of what seems to be a normal endometrial echo. Notice this is to the left of midline. To the right of midline, there's an obvious polyp. If we turn into a coronal view and look in the lower uterine segment, this looks perfectly normal. But in the fundus, here's the polyp. So I hope you all realize a long axis view here showed the polyp. A long axis view here looked absolutely normal. Here's an 8 millimeter endometrial thickness, very tempting to put in an endometrial sampler and take a piece of tissue. But when we put some fluid in here, sonohysterography, the pathology occupied about half of the surface area, but this half was normal. If you do a biopsy, this can be fraught with error, and we'll talk about this. And I brought the hysteroscopy of this patient to show you. She had complex atypical hyperplasia occupying about half of the cavity. I say here the standard of care has changed, but how many clinicians are aware of it? The reliability and liability of blind endometrial sampling has radically changed. So why is there an issue with such sampling? These suction piston biopsy instruments, they're smaller, cheaper, disposable plastic catheters that have an internal piston to generate suction. Now in the States, the Pipel brand has been so well marketed that our residents, registrars, have turned this into a verb. They will say, I Pipelled the patient. And I would say to you that half of you may say you're using a Pipel, even though you're using a different brand. Just like in the States, people will say, well, I'm going to the Xerox machine, but they own a different brand of copier. Or they may say, hand me a Kleenex when they have a different brand of tissue. So I got very interested in this topic. And if you go to PubMed and you put in the word pipelle, it was first described by Cornier in an article in the Gray Journal in 1984. In fact, it was called the Pipelle de Cornier. Of the next 8 papers, 7 dealt with endometrial dating as part of an infertility workup, which is what Cornier wanted to do. We no longer do this. 1 paper dealt with the amount of tissue obtained with Pipelle compared to the Vabra aspirator. But the next paper in 1991 was widely publicized. And this was an article by a guy named Tom Stovall. And what did he do? He took 40 women with known carcinoma. He did a Pipelle biopsy in clinic the week before their hysterectomy. He obtained cancer in 39 out of 40 patients. Hence, he said the accuracy was 97.5%. And this was widely publicized. Full page ads in all the journals. Pipelle sampling, 97.5% accurate. Well, Guido did a similar study, 1995. He took 65 patients, not 40 with known cancer. He did this Pipelle sampling under anesthesia prior to their hysterectomy in the OR. They missed 11 out of 65 cancers. But he did us the favor of opening the uteri. Of the cancers they missed, 3 were less than 5% of the surface area, 4 were less than 25% of the surface area, and 4 were less than 50% of the surface area. And of 11 that had tumors and polyps, 5 were missed. So Guido concludes Pipelle is excellent for detecting global processes in the endometrium. Well, other people have done something similar. I told you Stovall had a 2.5% false negative rate. These are women with known cancer. And I told you Guido missed almost 17%. Ferry, using a Pipelle, missed almost a third known cancer. And Larson, using a Z sampler, missed almost 18%. Well, so ACOG came out with a bulletin called Diagnosis of Abnormal Bleeding in Reproductive Aged Women, been reaffirmed several times since then. Tells us that 1/3 of outpatient visits to the gynecologist are for abnormal bleeding, and it accounts for more than 70% of GYN consults in the peri and postmenopausal years. Tells us that women aged 40 to menopause with abnormal bleeding, it may be due to anovulatory bleeding, which represents normal physiology in response to declining ovarian function, but it may also be due to cancer or hyperplasia or fibroids. Tells us that the primary imaging test of uterus for the evaluation of AUB is transvaginal ultrasound. Says that transvaginal ultrasound images are not adequate or further evaluation of the cavity is necessary, then sonohysterography, also called saline infusion sonohysterography, or hysteroscopy, preferably in an office setting, is recommended. So what is a sonohystogram? Well, if we put a little fluid into the endometrial cavity, it distends the cavity and enables us to see. These are some of the easiest ultrasound scans that you will ever perform. And the technical aspects are relatively simple for gynecologists, slightly more daunting for radiologists. But remember, fluid enhances sound transmission. That's why ultrasound is so valuable in obstetrics, babies in a bag of water. So sonohysterography should be thought of as a subset of transvaginal ultrasound when the endometrium is not sufficiently thin, when it's too thick, or it's not adequately seen. So what about these perimenopausal women who have abnormal bleeding? We looked at this with some length, and we found that 153 patients, 35% of our cohort, had to undergo sonohysterography. About 70% of those were for a thick endometrium. About a third, 29%, were for non-visualization of the endometrium. So here's an example of a sonohystogram. Here's a submucous myoma. The rest of the cavity is thin and atrophic. Here's a more modern clip of a negative sonohystogram. There's another sonohystogram showing a small polyp along the anterior wall. The rest of the cavity is thin and atrophic. And here's a sonohystogram on a patient with a symmetrically thick endometrium. which measured 5 and 4 millimeters anterior and posterior wall respectively. So this is a global process. This can get a blind biopsy. So in my opinion, it's no longer appropriate to do a blind office biopsy procedure unless you first verify that whatever the endometrial process is indeed global. But I wrote that slide 26 years ago. Thus, global process is suitable for blind sampling. Focal process should be handled by direct vision. So what about office hysteroscopy, which can be substituted for saline infusion sonohysterography? Previously, I haven't done this because of the space for the equipment, the need to sterilize the equipment, the time involved, issues of patient comfort or discomfort, but has not been a satisfactory option in my hands. But some of these newer disposable hysteroscopes have changed that for selected patients as an alternative to SIS in the office. So let me show you some cases quickly of office hysteroscopy. You know, this is somebody, you can slip a disposable hysteroscope in. Here's one polyp, here's another polyp. I'm done. I'm taking her to the operating theater in order to remove these polyps hysteroscopically. Here's an example of a submucous myoma. You can see the coarse vessels on the surface of the myoma, typical of a myoma. The rest of this cavity is pale and thin and has very little tissue. This was a patient on tamoxifen. Clearly, this is not a thin white line. Clearly, this doesn't prove inactive atrophic endometrium. And so we put our disposable hysteroscope in, and she's got a number of small, typical tamoxifen polyps. And you can see the microcystic change contained within this polyp under histologic examination. This patient had dysfunctional uterine bleeding, really not sure what her endometrium looks like on transvaginal ultrasound. We put our disposable hysteroscope in, and this fluffy stuff moving around. Remember, she's been bleeding, so there's areas of denuded endometrium, but there's no true polyp or true myoma. This is all typical of dysfunctional anovulatory bleeding. So in a case like this, you can go directly to a blind endometrial sample. She had proliferative endometrium. What is often told patients is hormone imbalance, and she gets treated hormonally and avoids any operative hysteroscopy. This patient had recurrent complex hyperplasia. So she had had a history of hyperplasia. She's got a thick endometrial echo. We slipped the disposable hysteroscope in. She's got patches of confluent areas. These areas are denuded because she has bled. I caution you not to make a histologic diagnosis based on visualization. But here, once again, without a focal abnormality, you can do blind sampling. She had a recurrence of her complex hyperplasia, and in spite of no atypia, she opted for hysterectomy instead of another prolonged course of a progestin. So back to the ACOG practice bulletin of July 2012. It tells us that an office endometrial biopsy is the first-line procedure of tissue sampling in the evaluation of patients with AUD over 45 years of age. Tells us that endometrial biopsy has high overall accuracy in diagnosing cancer when an adequate specimen is obtained and when the endometrial process is global. Tells us if the cancer occupies less than 50% of the surface area, then the cancer can be missed by a blind endometrial sample. Positive tests result more accurate for ruling in disease than a negative test for ruling it out. Well, that's true always. These tests are only an endpoint when they reveal cancer or atypical complex hyperplasia. So certainly now that the standard of care acknowledges that a negative blind biopsy is not always a stopping point, clinicians can certainly begin with a biopsy, but with any persistence, unless it is malignant or complex atypical hyperplasia, the endometrial evaluation is not complete. So in summary, the main use of endometrial thickness measured on transvaginal ultrasound is the high negative predictive value of a thin, distinct echo. Once again, use the word stripe. In most women with postmenopausal bleeding, an endometrial echo less than or equal to 4 millimeters has a very low risk of malignancy and does not require endometrial sampling. In premenopausal patients with AUB, an echo less than 5 millimeters early in the cycle excludes significant pathology. Otherwise, saline infusion sonohysterography or these disposable office hysteroscopies can distinguish global from focal and allow appropriate triage. new understanding about the high reliability of transvaginal ultrasound with saline infusion if necessary, or office hysteroscopy if necessary, as well as new understanding of the limitations of blind endometrial sampling will result in increasing importance and utilization of transvaginal ultrasound or office hysteroscopy in this common clinical entity of AUB and PMB in the years to come. And I thank you very much for your attention.
Thank you very much, Steve. Really appreciate that. And we're going to save the questions till the end. So now it gives me great pleasure to introduce our second speaker, Dr. Scott Chudnoff. Dr. Scott Chudnoff is the chair of the Department of Obstetrics and Gynecology and Women's Health at Maimonides Health in Brooklyn, New York. Before joining, he was the chair of the Department of Obstetrics and Gynecology at Stanford Health in Stamford, Connecticut. And previously, he served as the director of gynecology at Montefiore Medical Center, the fellowship director for the Minimally Invasive Gynecologic Surgery Fellowship, and associate residency director. And he's also currently a clinical professor of obstetrics and gynecology at Columbia University, Irving College of Physicians and Surgeons in New York City. He's a Brooklyn native. He went to Yeshiva University, Rutgers Medical School, has a master's of clinical science at Albert Einstein College of Medicine, and did his residency and fellowship in MIS at Montefiore Medical Center. So it gives me great pleasure to present Dr. Chudnoff, who's going to be speaking about medical management of abnormal uterine bleeding. Thank you, Scott.
Thank you. And so it really, I think Dr. Goldstein really hit the primary points in terms of understanding when we're thinking about treatment, we really have to be thinking about what's the underlying source and cause for the problem that they're experiencing. Just as a point of disclosures, you can see listed here. And what Dr. Goldstein brought up specifically related to the idea of the palm coin. And I think that this is really the basis when we're trying to understand our treatment. Understanding the primary underlying etiology is going to be critical for us in directing the appropriate management. And for a lot of conditions, there are both medical and surgical managements. What I'm going to concentrate on a little bit more during this talk is going to focus a little bit on the ovulatory and endometrial, although I will touch through some of the other parts of the palm coin description because they are all relevant and have significant sources. However, the objective of this talk was to focus on the medical management more so than surgical. And a lot of these things, the ovulatory dysfunction and the endometrial dysfunction are the things that tend to be the biggest problems that we find in the perimenopausal period and menopausal period, although all of them could potentially manifest during that period of time. So just again, when we think about it, I find it easy, as Dr. Goldstein had mentioned, between structural abnormalities versus identifying actual physiologic or causes underpinning the source of the bleeding. And I think it's important to keep in mind that while the majority of abnormal bleeding does come from the endometrium itself, it is possible for abnormal bleeding to be coming anywhere through the entire genitourinary tract, including the cervix and the vagina as well. And I will talk about that in a little bit more as well. So as was mentioned, polyps are a fairly common condition that happens. There's a baseline prevalence of about 15% for polyps. The majority of them are asymptomatic. And in general, when there is symptomatology, the recommendation for polyps is surgical removal of the polyps. And the primary reason is, as you could see, the polyp in that video that I just showed you there really is fairly large. It encompasses the lining, and you could understand how that polyp could potentially be a source of bleeding. Additionally, it is possible for polyps themselves to be containing malignancy, and therefore the critical nature of being able to remove polyps is something which is understated because of the fact that the simplicity in being able to remove those polyps. As Dr. Goldstein had mentioned, the ability for us to use hysteroscopy, I can tell you in my own personal practice, the majority of these polyps are things which are managed in the office setting. However, there are circumstances in which it would be a contraindication for us to be able to go to the operating room or even to try an office hysteroscopic removal of polyps. And in those circumstances, it is possible. There has been several studies which have been done looking specifically at the use of progesterones and GnRH agonists with the intent of being able to manage polyps. In some circumstances, what may look as a polyp on ultrasound may actually be a little bit of excess endometrial growth. Sometimes there could be a diagnosis as well of a clot that's there. And so sometimes the medical management with a progesterone or a GnRH agonist may be appropriate in those circumstances. Adenomyosis, and I'm going to go right through the palm coin. We'll use that as our skeleton in order to structure the talk today. While it is definitely possible that women could present with worsening symptoms in the perimenopause with adenomyosis, and a lot of that is driven due to the hormonal changes that happen in the transitional period. Adenomyosis should resolve with menopause. So people who are having abnormal bleeding as a result of adenomyosis will be able to get relief from that once they are in menopause. In most of these circumstances, we do manage them with continuous progesterones or a GnRH agonist or antagonist, as I mentioned before. The advantage that we see with some of the GnRH antagonists are the fact that we're able to actually utilize formulations that now incorporate with them hormonal add-back. So rather than our typical GnRH agonist, which we could additionally give estrogen or hormonal add-back to it, the use of the antagonists, the newer formulations do already have that incorporated, which makes it a little bit easier in order to be able to dose it for our patients. Fibroids can come in all types of sizes and shapes, and fibroids can cause a significant amount of problems. And it's interesting, the trajectory of fibroids in the perimenopausal period. We know that once menopause comes, the majority of fibroids shrink in size. One of the misconceptions, though, is that fibroids do not suddenly disappear at menopause, as do any of these conditions. It is a process over time, and fibroids will continuously shrink with menopause. However, as you can see in this one picture here, that what is overlying the top of the uterus there is a very large fibroid that's being held. But the location of the fibroids can all make a difference as to the symptomatology. But as I mentioned, the trajectory of fibroid growth can differ from patient to patient. We do sometimes see in the perimenopausal period an acceleration of fibroid growth, and much of that is postulated to be related to the hormonal changes within the transition period. Not everybody experiences that, and there is no consistent way in how people's fibroids will respond within the perimenopausal period. So it is important to keep that in mind when we're talking about the different treatment options. And as you can see over here, in regards to the medical options, the different medical options for fibroid treatments, the non-hormonal options include things such as NSAIDs and tranexamic acid, which is part of our standard armamentarium for any type of abnormal uterine bleeding. But additionally, the selective progesterone receptor modulators, which have actually been something which had gained a lot of interest, was already rolled out in Europe and had subsequently been pulled back because of several studies which have shown issues relating to potential liver malignancies as a result of it. It is something which is still being studied. There are certain countries which still permit it. Right now in the United States, it is not currently FDA approved. There are certain European countries which do allow the utilization of the sperms for the purpose of managing fibroids. Androgenic compounds are also something which are probably more relegated to the history books when it comes to the treatment of fibroids, primarily because of the side effects from it, specifically androgenization of a female, which many women do find uncomfortable or intolerable. We also have the selective estrogen receptor modulators, also considered to be relatively experimental with limited data over their efficacy. The same thing with aromatase inhibitors. The GnRH agonists and GnRH antagonists, as I mentioned, the GnRH antagonists have really splashed onto the scene in the last 5 to 10 years or so, and really have been picking up steam over the last several years as a viable option for the management of the fibroids. Aside from that, there are also surgical treatment options. And, while we're focusing on the medical options, it is always important to keep in mind that sometimes surgery is the most appropriate option for a patient. And there are a variety of different surgical treatment options for fibroids. As you could see here, everything from a myomectomy to a hysterectomy, and then a variety of less invasive surgical options as well. And the thing I always caution is that I generally recommend against myomectomies, at least abdominal myomectomies in the perimenopausal period. And typically I reserve that for individuals that are looking for future fertility because of the morbidity potentially associated, and would generally recommend a hysterectomy in that setting. However, recently I have been more enthused about offering the non-expirative options that you see here for patients in the perimenopausal period, because again, once patients get into menopause, the expectation is that those fibroids will shrink down in size and the symptoms will improve. Malignancy and hyperplasia, as you heard, are always critical for us both to evaluate and to rule out with any of the treatment options that we're contemplating. As a general rule, any hyperplasia with atypia and any malignancy should be surgically treated. And the medical management has been utilized in several of these cases when patients were not surgical candidates for a variety of reasons, whether it be poor cardiac function or severe obesity, which makes it nearly impossible to safely perform the procedures. However, as a recommendation that is out there, hyperplasia with atypia and anybody with malignancy should have surgical management. But as I mentioned, in very specific cases where surgery would be inappropriate, it is possible to manage these patients with high dose progesterones. And there's a variety of different options. There's been some work which has been done looking at utilizing the progesterone IUDs in these circumstances, along with an oral progesterone as well. However, the majority of cases will require a general high dose progesterone in order to be able to try to counteract it. If the decision is made to try medical management in somebody with hyperplasia and or malignancy, it is imperative that very close continued surveillance does take place. As I mentioned, I would not generally recommend that. That is my disclaimer about utilizing medical management in that setting, but it is always an option. Simple hyperplasia, on the other hand, is frequently the result of anovulation or excess estrogen. And therefore, in those circumstances, they can very easily be managed with cyclical hormonal management, typically either with a progesterone allowing withdrawal or a continuous progesterone agent as well, in order to be able to prevent that continued growth of the endometrium. Coagulopathy is not something we typically see as an initial onset at an older age. Usually if coagulopathy is present, it's usually identified in younger women. And in younger women, it can account for as much as 15% of patients with abnormal bleeding. However, the most common time we see coagulopathy in older patients that would be in the perimenopause or menopausal state tends to be iatrogenic, related to anticoagulation treatment or other types of medical treatments that might cause coagulopathy. So what I really wanted to focus on is the perimenopausal ovulatory dysfunction. And it's one of the most common sources of perimenopausal bleeding. And what we would expect in the menopause is that this bleeding should resolve. And it is a source of a lot of complaints for many patients, because in the perimenopause, when we think about the extremes of our ovulatory function in a female, both in the beginning of reproductive life and the end of reproductive life, the changes that occur, so we start to have a dysregulation of our HPO axis. And that subsequently can lead to a variety of issues as it pertains to our normal endometrial growth. We know that the normal endometrium has the two surfaces, our top layer, which is the functionalis. The functionalis is the part of the endometrium which grows within each cycle, and our basalis, which is the section of the endometrium which stays and is not sloughed off with the period. And what you can see very nicely on this image here are the spiral arteries that are present inside the functionalis layer. Now, what I wanted to point out with this, and I think it's important to keep in mind, is that what happens when we're having this dysregulation due to anovulation? And what we're seeing in those circumstances, that when ovulation is not occurring, the upper parts of the endometrium within that functionalis are not being supported appropriately. The progesterone essentially acts as braces for the endometrium. And what should happen in a normal cycle is the regulatory withdrawal of bleeding that happens due to the withdrawal of the progesterone. However, when ovulation doesn't occur, what ends up happening is there's a persistent low-level estrogen stimulation that occurs to the lining of the uterus. And the lining of the uterus will then subsequently grow at different rates. The problem with that multiple rate growth of the endometrium is that some parts of the endometrium will be much larger ahead than other parts. And we get the classic picture frequently of disordered proliferative endometrium when you do the biopsies in those patients. And as a result of that, what happens is patients may experience either irregular bleeding, where they either go extended periods of time without a period, they may find that they get bleeding too close together in those circumstances, or they may have a completely erratic pattern where they go for months without bleeding, then they'll bleed heavily for a week or two, then nothing, then they bleed again. The classic anovulatory bleeding pattern. Now, the nice part about the anovulatory bleeding pattern is that it actually is relatively easy to manage in the majority of patients, assuming that there aren't other dysfunctions that are present and other causes. And the other thing which I didn't mention at the beginning, which I think is key to keep in mind when we talk about all of these causes, are that it is not uncommon for more than one thing to be present amongst that POM coin diagnosis. And so while someone may have anovulatory bleeding, it is possible that they may also have a fibroid or adenomyosis or a polyp. And so therefore, sometimes treating only one structural component may not actually give the full relief that's necessary. And frequently that's because of the fact that there is the physiologic dysfunction that's accompanying it. So for anovulation, especially in the perimenopausal period, so our classic OCPs or combined oral contraceptives tend to be very effective in helping patients. That could include a standard birth control pill that has both an estrogen and a progesterone to it, the contraceptive patch and the contraceptive ring. And what are the main advantages, aside from the fact that it helps for that regulatory control of the HPO axis, is that it can also have a secondary benefit for many of our patients in the perimenopause, in that it can improve vasomotor symptoms. It can help with vaginal dryness in these patients. It can reduce the risk of osteoporosis, and it also can reduce the risk of endometrial and ovarian malignancies. However, it is important to keep in mind that we're giving agents that contain estrogens. And as a result of giving estrogens to a patient, we increase the risk of thrombotic events potentially occurring in these patients. And as patients age, the risk of thrombotic events naturally increases. And that's on top of the fact that there may be an increased risk due to a variety of medical contraindicated conditions, such as hypertension, diabetes, cardiac disease, and as well as certain malignancies where it would be contraindicated to be able to give somebody an estrogen. The other issue that we run into is when do we stop it, right? So if I give somebody a birth control pill, they are going to cycle, and even will cycle frequently, straight into the menopausal period. So the question then always arises, and this is one of the difficulties, is, well, when do we say, if I started somebody on OCPs, which for the right person is a wonderful option for them, right? Not to mention the fact that also, I didn't mention within the advantages, while rare, it is still possible that pregnancy can occur even in that perimenopausal period. I actually just had a patient recently, a 51-year-old patient who actually came in with a natural conception at 51. as you could imagine, her surprise. And this is a perfect example of somebody who probably would have benefited from the OCPs. Again, the natural fecundability of somebody who is already over 45 is quite low. Nevertheless, it is still possible, and there have been plenty of pregnancies reported within the perimenopausal period. But the big question then is, well, when do we stop using this? And so the problem is there is limited data on this. There have been several reports which have looked at the utilization of things like FSH and AMH levels at being able to determine, but those studies in general have been relatively small and confined to certain populations. And so therefore, the ability to reliably say based on FSH and AMH levels as to a wide population, I would say to use caution with it. A lot of it will come with a shared decision process with the individual patient of being able to, based on age. We know that the average patient in the United States, at least, goes into menopause between 51 to 52 years old. And so whether or not we want to time it based on age, as well as seeing symptomatology, are all aspects in how we would potentially manage that. Then the other option, the progesterone-only methods, which I tend to find myself using more commonly because of the number of patients who do have contraindications to estrogen compounds. And they come in all different formulations. They can be oral, they could be injectable, they could be implants, they could be IUDs. I can tell you for myself, the formulations that I most commonly am using myself are norethindrone, which I find very helpful for patients because it can also be very effective in suppressing other conditions that they may have underlying, whether it be adenomyosis or endometriosis as well. And the other is I will frequently cycle patients on medroxyprogesterone, where I would give them medroxyprogesterone for approximately 2 weeks and allow them to have a regular cycle, thereby basically filling in for their loss due to the anovulation of their cycle. But the injectables, the implants, and the Mirena IUD are all wonderful options, not just the Mirena, all the hormonal eluting IUDs are wonderful options. The only thing to keep in mind, and the advantage to some of the injectables and the IUDs are that may actually achieve amenorrhea for patients, which is something that they may choose and want to have happening. However, one of the disadvantages is that many times you get almost a boomerang effect. I may have treated the primary issue related to the anovulation, but sometimes you can create a hypoestrogenic state, which may cause irregular bleeding patterns, which you were originally intending to try to treat. Frequently, that will get better over time, the longer the patient uses the medication. But the question is whether or not the patients are able to tolerate it for the period of time necessary. The other option, which are also very good options, are the GnRH agonists and antagonists, as I mentioned previously. Now, they're a little bit more radical, and I like to use the term radical in them because of the fact that it does cause a complete hormonal withdrawal by using it. They also tend to be much more costly than the first-line hormonal agents. However, in women for who those other agents have either failed or are contraindicated, these can actually be wonderful for them. And frequently we can use these for patients as a bridge into menopause. The essential function of them and the way they work is that they cause a complete downregulation of the HPO axis, which essentially leads to a menopausal type state because of ovulatory withdrawal as a result of the use of the medicine. And then again, I mention it here just as a point of note that surgical management is always an option. Endometrial ablation historically has been something which is commonly used for patients with dysfunctional uterine bleeding and can be helpful for patients in that perimenopausal period. And hysterectomy is always an option as well for patients who either have failed or continuously are having other issues that are there. Then moving along here, and I know I'm going a little over time here, so I'm going to try to pick up my pace for a second here. The other big thing is endometrial. And so some of the classic endometrial issues that you may run into, something like chronic endometritis. It generally presents with irregular bleeding or spotting. If on a biopsy, there are no other identifiable causes of why somebody may be experiencing abnormal bleeding, and I usually use this more of a diagnosis of exclusion than my primary diagnosis, I can sometimes treat these patients, and I would treat them, the treatment regimen that I typically use is doxycycline, 100 milligrams BID for 10 to 14 days. It is also important to make sure about STDs and cervical dysplasia, which also are potential sources. But I think that the other big thing to keep in mind is atrophy. And this is really the last major point that I want to get to. Atrophy is one of the most common causes of abnormal vaginal bleeding, particularly in the postmenopausal period, but we can also see it in the perimenopausal transition. And remember, atrophy is not necessarily limited to the uterus itself and the endometrium, but we could have vulvovaginal atrophy, where the vagina itself is atrophic and there's a thinning of the mucosa of the vagina, which can then cause trauma due to rubbing of the vaginal walls against each other. I usually start, if I do suspect vulvovaginal atrophy, I usually start with vaginal moisturizers and lubricants, particularly during coitus. I just want to point out that there is a difference between a vaginal moisturizer and a lubricant. They are different types of agents and they are intended to be used differently. Vaginal moisturizers tend to have longer staying power. They tend to be composed of a hyaluronic acid, and they're typically prescribed once every other day or about 3 times a week. Lubricants are intended to be used primarily during coitus in order to be able to facilitate and improve lubrication. If those fail, and I do suspect vaginal atrophy, then vaginal estrogen therapy is the next line that I will go to with a lot of these patients, which could lead to restoration of the normal vaginal acidic pH and microflora and a thickening of the epithelium. It is important to keep in mind that vaginal estrogen does have absorption, albeit to a lesser degree than our oral agents. And here's an example of some of the vaginal estrogens that are out there. This is merely a sampling of just some of the ones that are available inside the United States right now. I think that as it pertains to preferences, a lot of it has to do with patient preferences to the type of formulation, whether they prefer an insert, a cream, or a ring, but they are all very effective at helping for atrophy, vulvovaginal atrophy. And then endometrial atrophy is, again, another potential problem. And if we think about it, if the endometrium itself is a potential space, the endometrium is not open, it is the 2 sides of the endometrium are normally in approximation to each other. So what that essentially means is that if there is rubbing that takes place, it is possible for that endometrium to subsequently bleed. Now, it's not very common to see excessive bleeding as a result of endometrial atrophy, but we do see this in the postmenopausal period, and it is one of the more common causes and sources of postmenopausal bleeding once other sources such as hyperplasia and malignancy have been ruled out. And it typically is the result of the lack of estrogen or prolonged progesterone use. Now, there is a large number of preparations that exist in regards to the utilization of oral or systemic types of hormones in order to help for the purposes of people with endometrial atrophy. The only point of caution I will give everybody is that if the uterus obviously is still in place, there does need to be a progesterone as well given in order to counteract the estrogen. And this can be done in a variety of different formulations, both formulations which combine both, others where you can do it cyclically by giving estrogen and then giving progesterone, or giving both simultaneously. And as you could see here, the number of methods that exist and what's out there, and as well as the ways to administer it are enormous. The last thing, just to finish up, iatrogenic causes. I did mention about anticoagulation. I mentioned about HRT and sex steroid administration. But the other things to keep in mind are hypothalamic depressants, digitalis, and phenytoin are also agents which have been known to be associated with abnormal bleeding. And then lastly, remember, there's always a lot more than just the uterus and or the vagina. We did mention about the vagina, but there's also vulvar conditions such as lichen sclerosis or various other lichen conditions, infectious diseases, urinary and anorectal and bowel sources as well.
Thanks so much, Scott and Steve. And I think you both gave superb talks, and particularly you can appreciate your practical knowledge and your useful advice to OBGYNs in the audience. And I personally learned a few things, so you can even teach an old dog new tricks. So thank you very, very much. So we have now 18 questions, and I hope everybody will stick around for the question and answers. And we plan to go through them chronologically. So from Manju Navani for Steve, what fluid or liquid is used for an SIS?
Well, actually, the word SIS actually was coined by Linda Bradley, stands for saline infusion sonohysterography. So I do use saline. In Europe, there are some people who are using gel. You know, any liquid really can distend the endometrial cavity and give you the visualization that you need.
So do you have like a little kit and put how many cc's? You put 5 cc's or how much, or 3 cc's? Can you tell us exactly how you do it?
I think other people do it differently. We have drawn up, we use 12 cc syringes. They're pre-filled by my medical assistant. She's sterilely, she's got them available. And, you know, in some cases, that may be sufficient. You know, different uteri expand differently. Sometimes as quickly as you put fluid in, the fluid runs out of the fallopian tube. You see it in the cul-de-sac. Other times, even a small amount of fluid distends the cavity. You just want to, I'm often asked, how much fluid do you use? It's not how much you use, it's what you see. So you want to get adequate visualization of the endometrial cavity, and that will determine how much fluid I inject.
Okay, thank you. And what is the cutoff used for endometrial thickness in patients on sequential hormone therapy if the scan is done at the end of withdrawal bleed? And is there even a cutoff?
Yeah, I mean, this hasn't been as well established, but you would expect that if somebody is on estrogen, you give them sequential progestogen, they get a withdrawal bleed, it should be, depending if you've done it right away, it should be thin. And once again, you know, the reason that ACOG now has a 3, 4, and 5 millimeter risk assessment is there's no magic number. You know, there's a little bit of judgment. I mean, I've always worried the machine, as I said, measures to 100th. So, you know, people measure an endometrium and it's 3.98 millimeters and they think everything's fine, and measures 4.02. Oh, they'll go all the way to hysterectomy to get a piece of tissue. Where's the thinking? You know, think about the clinical backdrop, think about your concerns. So I think that this 4 millimeter notion, if at the end of a withdrawal bleed, it is thin, you have excluded significant tissue. If there's any doubt that, or the patient has other risk factors, then you may want to get a little more aggressive, saline infusion, office hysteroscopy, you know?
Yeah, and that's only where the bleeding is abnormal. If you have someone who's having a regular withdrawal bleed, do you even care?
No, in other words, it's been well shown, Malcolm Whitehead did that. Patients who were receiving sequential progestogen, if they bled on day 9 or 10 of the 10-day course in those days, this goes back to the late 70s, 100% of the time they were okay. So if people bleed at the right time of the sequential HT, there's no need for you to evaluate them at all. It's when they have abnormal bleeding on sequential HT that you might want to do this.
So this is from Anonymous. What is a normal endometrial thickness for patients on tamoxifen? And why are you even doing an ultrasound?
Yeah, well, that's a whole nother lecture, which I'd love to give someday. In fact, if you come to the World Congress in Lisbon, for once, I am not speaking on evaluation of the endometrium, but I'm speaking on SERMs, and tamoxifen is the original SERM in HRT, and tamoxifen is an unusual drug in the endometrium. It causes some glandular cystic atrophy, these microcystic changes. In the early days, it was interpreted as endometrial thickening, but when you look at it, most of these patients with saline infusion, they actually have atrophic endometrium, but they have funny looking ultrasounds. It also produces a lot of benign polyps, but it does produce some endometrial hyperplasias and even a small number of cancers. So there really is no normal thickness. If a tamoxifen patient is bled, I would triage her in the same way that we do now. If you are lucky enough to get a thin white line, you're probably done. If not, I go to saline infusion and I look at the endometrium itself, not the microcystic change that looked heterogeneous to start with.
Yeah, and to emphasize that if the patient is not bleeding, routine ultrasound is not recommended.
I mean, if you really want to get down to it, the ACOG technical bulletin on this references work by Martine Berlier in Brussels. If you pre-screen patients who are going on tamoxifen, if they have a squeaky clean uterus to start with, in other words, they have a thin, distinct echo, they have no evidence of, let's say, a benign polyp, their incidence of endometrial hyperplasia through 5 years of tamoxifen was no different than the background noise. But 17% of women going on tamoxifen has an asymptomatic polyp. When they removed these and then treated these women, almost 12% developed atypical hyperplasia. So that's 18 times the risk of the background noise. So you could make an argument if you're putting a patient on tamoxifen, pre-screen their endometrium to a high risk versus low risk. The squeaky clean endometrium is low risk. If it's not squeaky clean, then it may have greater risk.
What is the effect of hormone therapy on fibroids? And when is it contraindicated, if ever? Either one of you.
Yeah, and I think Scott alluded to this very nicely, that we tell patients that after menopause, your fibroids will shrink some, they do not go away. In patients who go on hormone replacement therapy, you often don't get that degree of shrinkage. You may or you may not, it's variable. But it's not contraindicated based on the fibroids themselves. Sometimes people with submucous fibroids may have some episodes of bleeding though, but it's certainly not contraindicated.
Scott, do you have any answer on that too, or?
Similarly, I generally always have a little bit of caution with HRT when patients have had significant fibroid symptoms prior to menopause, because again, it is possible for those fibroids, while we don't expect them to grow due to HRT, but some of the bleeding symptomatology, particularly if they're submucosal fibroids, may recur again when they are started on HRT.
So I have a question. Have you used TXA with OCP in patients that are bleeding heavily, and have you seen any thrombosis?
Yes, I have. No, I have not seen any thrombosis as a result of it. There's been, I know this is one of the controversial topics in the United States, which there have been actually several publications out there about the utilization, because I know that in Europe, it is widely accepted to be able to use TXA while taking OCPs. In the US, it was initially listed as a contraindication for taking them both due to the risk of it, but pretty much all of the data out there does not really demonstrate any significant increased risk by taking both simultaneously.
Okay, how effective is micronized progesterone in preventing endometrial cancer in hormone therapy? Do you recommend increasing dose with the higher doses of estrogen? And at what doses of estrogen will you increase your dose of progesterone in sequential and continuous combined HRT regimes?
So personally, I usually go with standardized regimens for it. My increase in the amounts that I'll be using are going to be contingent based on symptomatology of why I'm giving the HRT in the first place. And the only time I would go significantly higher in my progesterone is if as a result of the HRT. So commonly what I'll see is that I started someone for HRT for another problem, not necessarily related to the bleeding, and then subsequently they will start to experience bleeding, at which point then I will titrate the progesterone as needed, should it be ineffective in terms of that control. As a general rule, I don't believe that you will need significantly elevated levels of the progesterone, and even if you go up on your estrogens, you won't necessarily need to go much higher with the progesterones, simply because of the fact that the main objective is stabilization which tends to happen even with the lower doses of the progesterone. I don't know if Dr. Goldstein also.
Yeah, I would
wants to
jump in
comment.
here. I would say that, people for quite some time now have started to use 100 milligrams of micronized progesterone for continuous combined HT. And until Bijuva in the States came out and had a clinical trial that proved that that was approved and endometrially safe, there was really no evidence to support that. And I will also tell you that I have the occasional patient who thickens her endometrium on that regimen, where you substitute 100 milligrams of micronized progesterone for continuous combined. And when those patients I've given a standard dose of medroxyprogesterone acetate, they then have bled, thinned their endometrium. So I don't think that micronized progesterone in that dose across the board is quite as good a progestogen, although I start with that, but keep in mind that sometimes it doesn't do the trick. And I don't normally go up on doses. If people have any abnormal bleeding, then I'll triage them according to the way we talked about.
Yeah, I have a pretty strong opinion about this because I have a POI clinic. So we use a lot of higher doses of estrogen, like 100 micrograms of estradiol. And just if I go with a routine progesterone, it's usually okay for a year or even year and a half. And then 2 years, they start having bleeding. So I think we really need to do more trials on higher doses of estrogen and the adequate amount of progesterone or progestin to protect the endometrium. I know that I believe Nelson did a trial using 100 of estradiol transdermally with 10 milligrams of MPA sequentially, and had endometrial protection. It's an older study. So even though MPA is not my favorite, sometimes we'll use that as an endometrial protective.
Yeah. I do think the POI patients are extremely different and a whole other topic that we should have a webinar about again.
Okay. So from Pilar La Fuente, simple hyperplasia in postmenopausal women, only risk factor, a lot of sport, no anabolic agents. Would you manage with progesterone and how much time?
So I would manage with progesterone in that circumstance. I think that as a general rule, one of the questions always is what is potentially causing that and what's the underlying source. It said in the question, it said no underlying risk factors, but frequently, especially we know as obesity is increasing, obesity it is in and of itself a risk factor. For me personally, in terms of the way that I would manage, I usually give them the progesterone for at least 6 months, assuming that there's no other underlying etiology, and I would resample them to determine what's going on and manage based on how their symptomatology is from there.
Okay. Steve?
In terms of
Simple hyperplasia management.
yeah, I mean, I think everybody has their own favorite regimen. Some people, I've seen people use 3 months of continuous medroxyprogesterone acetate. I know that putting in a levonorgestrel IUD has become very popular, although I'm not 100% sure what the data for that is in terms of long term. This is not a pre-malignant factor. And I think, as has kind of been mentioned, it is interesting. There's usually some risk factor, which is may or may not be modifiable. So,
do you ever see it just temporarily in the perimenopause in an anovulatory patient who's in this patient that Dr. La Fuente mentioned?
so
Temporary.
I am a huge fan in people who have no contraindication in the perimenopause of 10 microgram birth control pills.
I'm sorry, what did you say?
10 microgram birth control pills if there's no contraindication, because I think that the key in perimenopausal women is to turn off the erratic production of estradiol. And so if you can't use a birth control pill, then periodic use of a progestogen is going to be my second choice. But that doesn't stop the erratic production of estradiol that these women often have, which is the culprit. And so if at all possible, I would use a low-dose birth control pill.
What do you think about inserting a Mirena IUD in patients that are really obese as a protective for their endometrium? I don't know if there's been any trials.
Well, that's what I'm saying. I think this has become very popular. People are doing this a lot and they're convinced that it works. But I don't know that there's good long-term data, especially in somebody who's very obese, who's got risk factors. And, certainly the problem for me for IUDs is it makes endometrial evaluation very, very difficult. You can't really do ultrasound. You can't really do saline infusion. I mean, I have not been a huge fan of this for somebody with simple hyperplasia.
Okay, would you please comment on the choice of OCP in this population in terms of formulation? I understand the UK it's contraindicated after age 50, but in many other countries can be used up to age 55. Secondly, do you usually use progesterone alone, cyclically or continuously? You mentioned cyclic MPA. Could you achieve the same effect with cyclic NIDA or Prometrium?
Well, you ask a lot of things at one time.
That's a lot.
I want to make a comment about the use of the OCs. When I wrote a book with Nanette Santoro on perimenopausal gynecology, Patsy Sulak wrote the chapter on birth control pills. And she recommended keeping people on the pill till they're 55, because by that time, 90% of women are menopausal. I've never loved that across the board, because then you're treating a number of menopausal women with low-dose birth control pills for 1, 2, 3 years. But I think this concept of stopping at 50 is ridiculous. I think you have to individualize. Your patient who is 51, 52, doing very well, very nicely regulated, feeling very good. She's thin, she's athletic, she has normal blood pressure, she clearly has never smoked, she has no comorbidities. I'll continue her a little longer. My patient who's obese, a type 2 diabetic waiting to be discovered, borderline normal blood pressure, but sort of high normal, I'm a little nervous. So I think there's room here for individualization and judgment, not a cutoff of 49 11 months, you get it, and 50 in 1 month, you have to come off. And I think we're almost out of time, Wendy.
Do you use these low dose OCPs, the 10 micrograms?
My favorite.
Yeah. Okay, maybe can we do one more? We've
Sure.
got so many questions. Let's see. In terms of control of bleeding, is there a preferable progestin? Do you use, I think you mentioned this, Scott, do you prefer MPA? Do you prefer norlutate?
I personally prefer norethindrone acetate, because I find that there are a larger number of patients with underlying endometriosis and or adenomyosis. And I find that putting them on a continuous norethindrone helps both by creating amenorrhea for them and potentially better suppressing if there is an underlying endometriosis or adenomyosis. I also find that in general, in my experience, if they were going for continuous, I find that they tend to tolerate the norethindrone acetate better than a continuous MPA. So that generally is my first line for it.
Does anybody have experience with the new drospirenone 4 milligram use in this
Yes.
age group?
Yes, I've seen it, and I've seen some very good results from it, and I've seen some very bad results from it. So I'm waiting for a larger N for myself before I start to make a definitive opinion about it. But I have seen at this point probably about 24 patients who have used it, and in that period of time, I've seen about a split. What I find is that a lot of these patients, after they've been on it for about 3 to 6 months, start to come back with continued bleeding issues. And so, like I said, I think I personally need more data before I could say anything.
Okay, well, I'd like to thank everybody very much. And I'm sorry we can't get to all the questions. We had a lot of people participating today, and I think we had a really successful session. I'd like to thank Dr. Goldstein and Dr. Chudnoff, and I'd like to thank Basan again for sponsoring this talk. And I'd also like to remind everybody to try and attend the IMS in person.
Thank you, Wendy. And thank you all. Hope to see you all in Lisbon.
Yes,
Bye now.
thank you. Thank you for the
Thanks a
invite.
lot. Bye.
Bye.